Figure 2-1 shows a mature cystic teratoma or dermoid tumor. Dermoids, the most frequent germ cell tumors and the most common neoplastic cysts observed in adolescence, are benign and sometimes bilateral in 7% of cases. They contain cells from at least 2 germ cell layers and often contain hair, sebum, and teeth. Although dermoids have a wide range of appearance on ultrasonography, based on the type of tissue present, some common features include the following: a shadowing echodensity, diffuse or regional high-amplitude echoes, fat fluid levels, intracystic floating balls. The presence of 2 or more characteristic signs is associated with a high positive predictive value of correctly identifying a dermoid cyst. Additionally, the presence of ovarian calcification on abdominal flat plate, pelvic magnetic resonance imaging, or pelvic computed tomography studies should raise suspicion for a dermoid. Dermoid cysts typically have a cystic component. A solid adnexal mass in an adolescent should raise suspicion for immature teratomas or other germ cell tumors. Tumor markers are indicated in this scenario. Dermoids can present with dull abdominal pain but are frequently asymptomatic and often found by examination or incidental imaging. Dermoids also may present acutely with ovarian torsion, from the weight of the contents of the cyst, their ability to enlarge rapidly, or their floating location in the pelvis caused by high fat content. Because ovarian dermoids are neoplastic and do not spontaneously regress, many cases require surgical intervention. The focus should be on fertility-sparing procedures for young women, most typically laparoscopic ovarian cystectomy. Dermoid cysts rarely rupture spontaneously, but, if they do, chemical peritonitis, foreign body reaction, or dense adhesions may result. Small, asymptomatic dermoids may be monitored with the use of ultrasonography. Although endometriosis frequently is identified laparoscopically in adolescents with refractory dysmenorrhea, endometriomas are uncommon. The ultrasonographic appearance of an endometrioma includes a low, homogeneous echogenicity, often described as a ground glass appearance. An endometrioma Fig. 222 requires fertility-sparing surgical removal with complete removal of cyst wall to prevent recurrence. A hydrosalpinx is a post-inflammatory abnormality of the fallopian tube. Proximal and distal ends become scarred, which leads to accumulation of serous fluid and swelling. A hydrosalpinx Fig. 2-3 can mimic a complex ovarian mass because the dilated tube folds on itself, which gives the impression of a septation within an ovarian cyst. Patients with hydrosalpinx typically are asymptomatic, and no intervention is indicated. A hemorrhagic ovarian cyst Fig. 2-4 typically is complex in nature and resolves over time. Although hemorrhagic ovarian cysts often can be the cause of lower abdominal discomfort, they can be monitored by ultrasonography unless intraperitoneal bleeding is identified. Ectopic pregnancy Fig. 2-5 is a diagnosis that should be considered in any young patient who has abdominal pain or abnormal bleeding. An ectopic pregnancy can be easily ruled out with a negative result of a pregnancy test. Ultrasonographic findings in ectopic pregnancy can include an extrauterine embryo with cardiac activity, adnexal fluid with a yolk sac or embryo, a tubal ring, or complex or solid adnexal masses. Ectopic pregnancy can be managed either surgically or medically, in appropriately chosen patients.